When we talk about stroke in children, most people picture an ischemic stroke, a blocked artery. But nearly half of all pediatric strokes are hemorrhagic, bleeding inside the brain. And unlike ischemic stroke, hemorrhagic stroke in children carries a higher mortality. It can be rapidly fatal. Today, we are doing a deep dive into hemorrhagic stroke in children. What it is, how it is classified, what causes it, how we diagnose it, and how we manage it. Whether you're a medical student, a pediatric trainee, or a parent trying to understand what happened to your child, this one's for you. I'm Dr. Aditi Goimawala Garg. Let's get into it. What is hemorrhagic stroke? Hemorrhagic stroke, or HS, refers to non-traumatic intracranial bleeding, and it's classified based on where the blood collects inside the skull. How common is this in children? According to UpToDate, the incidence of hemorrhagic stroke in the pediatric population is approximately 1.5 to 5 per 1 lakh children per year. And critically, HS accounts for roughly 50% of all pediatric strokes. That's a striking statistic, especially when you compare it with adults, where ischemic strokes dominate. Two important points right at the start. 1. HS can be rapidly fatal. 2. While mortality is higher than arterial ischemic stroke, long-term neurological deficits are paradoxically less common in survivors, likely due to the plasticity of the developing brain. Now, let's understand the 5 compartments where bleeding can occur. This is the scaffold for everything else in this talk. First, intraparenchymal hemorrhage or IPH, blood within the brain substance itself. It can occur anywhere: the basal ganglia, white matter, cerebellum, brain stem. Think AVMs, hypertension, tumor bleeds. Second, intraventricular hemorrhage or IVH, blood within the ventricles. It can be isolated or an extension of a parenchymal bleed. This is the hallmark of the premature infant. Third, subarachnoid hemorrhage or SAH, blood in the subarachnoid space between the pia and the arachnoid matter. In children, AVMs are the single most common cause, not aneurysms, unlike in adults. Fourth, subdural hematoma or SDH, blood between the dura and the arachnoid. This can be spontaneous in children with brain atrophy because the bridging veins stretch. And critically, in infants, subdural blood without a trauma history should immediately trigger the evaluation for abusive head trauma. Fifth, epidural hematoma, EDH, between the skull and the dura. This is almost always traumatic, middle meningeal artery injury, typically with a skull fracture, and strictly speaking falls outside spontaneous hemorrhagic stroke. So, how does a child with hemorrhagic stroke present? It depends on location, cause, and speed of bleeding, but there are some classic features. Acute presentations can include a thunderclap headache, that sudden, severe, worst headache of my life, or an instantaneous headache, loss of consciousness, knuckle rigidity, suggesting blood in the subarachnoid space, focal neurological deficits, and seizures. In bleeds associated with vascular malformations, you may hear about pulsatile tinnitus, a cranial brew on auscultation, macrocephaly, especially in infants. This is the vein of Galen malformation picture, and even high output cardiac failure in a neonate. Now a word on abusive head trauma, because this is where a pediatrician can truly save a child's life. The presentation may be a subdural or parenchymal bleed with no apparent trauma history. What you must actively look for: subtle scalp, suborbital or ear bruising, retinal hemorrhages in multiple layers. This is classic and requires urgent ophthalmology review. Chronic failure to thrive. And in any infant with subdural blood, get a skeletal survey to rule out fractures. This is mandatory. Now, let's get into causes. I've split this into vascular malformations, which are structural lesions, and then the systemic causes. Arteriovenous malformations, AVMs, are the single most common cause of both subarachnoid and intraparenchymal HS in children. They can occur anywhere in the brain. The annual bleed risk is approximately 2 to 4% per year throughout life. So a child diagnosed at 6 years has a lifetime of compounding risk. An interesting recent finding: somatic KRAS gene variants have been identified in some patients with brain AVMs. This has implications for future targeted therapy. Vein of Galen malformation is a specific entity where there is an arteriovenous fistula draining into the great cerebral vein. In neonate, the presentation is dramatic. High output cardiac failure, progressive macrocephaly, dilated scalp veins, prominent cranial brow. Hemorrhage itself is actually rare. The main issues are the cardiac and hydrocephalus complications. The primary treatment is endovascular embolization. Cavernous angiomas or cavernomas. These are low pressure lesions with silent microbleeds. On MRI, they have the classic popcorn appearance with a hemosiderin rim on SWI sequences. They can be sporadic or familial, autosomal dominant, associated with variants in CCM1, CCM2 or CCM3 genes. Rebleed risk is approximately 0.5 to 3% per lesion per year. Surgery is considered for accessible symptomatic lesions. Cerebral aneurysms are a less common cause of SAH in children compared to adults. When you do see them, think of an underlying condition: polycystic kidney disease, infective endocarditis, or connective tissue disorders like Ehlers-Danlos syndrome or Marfan syndrome. Conventional catheter DSA remains the gold standard for delineating aneurysm anatomy before treatment. Beyond vascular malformations, a wide range of systemic conditions can cause hemorrhagic stroke in children. Hematologic causes include thrombocytopenic purpura, both ITP and the more sinister TTP, hemophilia A and B, DIC from sepsis or liver failure, and anticoagulant therapy including warfarin. The management implications here is important. You may need urgent reversal with vitamin K, fresh flows in plasma, or prothrombin complex concentrate. Vascular arterial disease is worth highlighting. Moya-moya, fibromuscular dysplasia, vasculitis, and intracranial dissection are conditions we more commonly associate with ischemic stroke. But they can all cause hemorrhage as well. A special mention for sickle cell disease. These children develop large vessel vasculopathy with progressive arterial stenosis. They are at risk for both ischemic and hemorrhagic stroke. This is why transcranial Doppler screening is recommended annually from age 2 in all children with HBSS and HBS-beta 0 thalassemia. Brain tumor bleed can present as a primary hemorrhage and in some case series is a surprisingly common cause. Always consider imaging in an underlying mass when you see an unexpected parenchymal bleed. And finally, hemorrhagic transformation of ischemic stroke, particularly in the context of cerebral sinovenous thrombosis, CSVT. Venous infarcts are inherently hemorrhagic and can be difficult to distinguish from primary HS, which is why we always look at imaging carefully for signs of sinovenous thrombosis. Neonatal hemorrhagic stroke is its own chapter. It really has unique features. In the preterm infant, the most characteristic lesion is germinal matrix hemorrhage with IVH. The germinal matrix is the highly vascularized periventricular tissue that is present only in the immature brain, and it's extremely fragile. Bleeds are graded 1 through 4 on the Papile classification, which you are looking at on the slide now. Grade 3 is IVH with ventricular dilatation. Grade 4, which we now better understand as periventricular venous infarction rather than simply extension, carries the highest risk of long-term hemorrhagia. Cranial ultrasound is the primary imaging modality in preterm infants. An important point: germinal matrix injury can also occur in utero, leading to periventricular venous infarction that only becomes apparent in later infancy as chronic hemiparesis. In the term neonate, the picture is different. More than 50% of term neonatal HS may be idiopathic, which is a striking fact and speaks how poorly studied this population is. When a cause is found, consider CSVT. Term IVH is often secondary to deep sinovenous thrombosis. MRI with MR venography is essential. Let's talk imaging. Your first line investigation for any suspected acute intracranial hemorrhage is a non-contrast CT scan. It's fast, widely available, and highly sensitive for acute blood. The hyperdensity of fresh hemorrhage is unmistakable on CT. However, CT can miss subacute or chronic bleeds and has limited sensitivity for small subarachnoid hemorrhage. MRI brain, particularly GRE and SWI sequences, is superior for detecting even tiny amounts of blood, both acute and old. Hemosiderin deposits from previous microbleeds, as in cavernomas, show up beautifully on SWI. MRI offers significantly improved diagnostic accuracy over CT overall. If your clinical suspicion for SAH is high, but the CT is negative, lumbar puncture is essential. The key is timing. Wait for at least 6 to 12 hours from symptom onset for xanthochromia to develop. It peaks at 12 hours and persists for up to 2 weeks. And this is critical. In every child with intracranial hemorrhage, you must perform vascular imaging. CTA is fast and excellent for AVMs and aneurysms. MRA avoids radiation, but conventional catheter DSA remains the gold standard for delineating vascular anatomy before intervention. This is required to exclude underlying vascular abnormalities including AVMs, aneurysms, and fistulas. Management is a four-pronged acute approach followed by definitive treatment of the underlying cause. Step 1. Stabilize. Airway, breathing, circulation, PICU, admission. Urgent neurosurgical consultation. This is not a call in the morning situation. Step 2. Neuroprotection. The same principles that apply in ischemic stroke apply here. Head of bed at 30 degrees. Strict normoglycemia and normothermia. Avoid hypoxia and hypercapnia. Both raise intracranial pressure. These neuroprotective principles are paramount in the vulnerable pediatric brain. Step 3. Reverse coagulopathy. If the child is on warfarin or has an acquired coagulopathy, vitamin K, FFP, and or prothrombin complex concentrate as indicated. Thrombocytopenic bleeding requires platelet transfusion. Step 4. Seizure control. Seizures are common in HS and increase metabolic demand in an already injured brain. IV levetiracetam is commonly used. Continuous EEG monitoring is important. Subclinical seizures are easy to miss. Prolonged AED therapy if epilepsy develops. On the surgical and interventional side, emergency craniotomy for large or rapidly expanding hematomas. AVMs are treated with a combined approach: endovascular embolization, radiosurgery, gamma knife, and or microsurgery, depending on size and location. Aneurysms are treated by clipping or endovascular coiling. Cavernomas, surgical resection if accessible and symptomatic. Complex vascular malformations often require a multidisciplinary team approach. What happens to these children? Mortality is higher than arterial ischemic stroke and depends on lesion size, location, and etiology. Large hemispheric bleeds and posterior fossa hemorrhages carry the worst prognosis. But here's the hopeful part. Among survivors, especially younger children, the developing brain has remarkable plasticity. Long-term neurological deficits are less common than you might expect given the acute severity. Cognitive, motor, and language outcomes are generally better than equivalent bleeds in adults, particularly when onset is before 5 years of age. That said, if there's a structural lesion like an AVM or cavernoma, the recurrence risk is significant. AVMs carry 2 to 4% annual rebleed risk. Cavernomas 0.5 to 3% per lesion per year. Serial imaging is essential, and definitive repair or removal of the vascular malformation, when achievable, significantly reduces long-term recurrence risk. These are the causes of spontaneous subarachnoid hemorrhage in young adults and the causes of spontaneous ICH in young adults. These are key exam and clinical reference tables, so pause here when studying. So, to summarize, hemorrhagic stroke in children is a medical emergency accounting for around half of all pediatric strokes. It is classified by compartment: intraparenchymal, intraventricular, subarachnoid, subdural, epidural. AVMs are the most common structural cause. Always exclude abusive head trauma in infants with unexplained STH. Imaging starts with CT, but always include MRI and vascular imaging. Management requires stabilization, neuroprotection, reversal of coagulopathy, seizure control, and definitive treatment of the underlying lesion. All sources are on the final slide. If you found this useful, like this video, share it with a colleague, and subscribe for weekly pediatric neurology content. See you in the next one.